Good afternoon, everyone. Let's give 1 minute more to wait for further attendees before we start the webinar. Let's give it just 1 minute more. Okay, then good afternoon, everyone. Thank you so much for joining to this collaborative webinar in which we will showcase the groundbreaking efforts of EU for Health funded projects in providing vital mental health support for Ukrainian displaced people amidst the ongoing crisis. I will move forward into the housekeeping rules for our webinar. So please note that there will be 2 online surveys. Both of them will be presented in English and Ukrainian. Please note that we have available Ukrainian interpretation. You can choose one of the features for this interpretation as well. So please mute the English channel and switch into the Ukrainian channel. Also, please note this webinar is being recorded and the recording will be available on the Child Hub website. I will post this link later on. Please mute your microphone, turn off your video during the webinar, and please note that at any time you can ask questions in the Q&A box in which we will address them at the end of the webinar. At this moment, I would like to ask my colleague HaDEA to launch the first poll questions. Perfect. Perfect. Thanks a lot for your answers. Then I will move forward to discuss our agenda today. So as most of you know, our webinar today will focus on showcasing the groundbreaking work efforts of EU for Health funded projects in providing mental health support for Ukrainian displaced people amidst the ongoing crisis. So HaDEA has propelled pioneering projects like You Rise, and MESUR, who are dedicated to fortifying mental health resilience and support networks for displaced populations. So during this webinar, we will delve into the strategies employed by each project to empower non-specialized professionals in providing culturally sensitive trauma-informed care to Ukrainian people. Our discussions will explore scalable approaches aimed at enhancing mental health and psychosocial well-being, all prioritizing accessibility and long-term sustainability. So our agenda for today will feature concise presentations from each project, followed by engaging discussions where we will present some discussions, questions, and then at the end, everyone will have the opportunity to ask questions to the speakers. And I would like to then move forward into presenting our speakers for today. Then we have Sinje Selig. She's a psychologist with a master's in neuropsychology from Bristol, UK, and a doctorate from Heidelberg University in Germany. She focuses on neuropsychology and dementia research, and she currently works as the project manager at the European Alliance Against Depression. And she oversees EU-funded projects such as MESUR. Irina Frankova, she's a postdoctoral researcher at the Department of Clinical, Neuro, and Developmental Psychology at the Free University of Amsterdam. She's currently a senior researcher at the ARQ Centrum 45 in the Netherlands. And Dr. Frankova, she currently leads the work package for URISE on networking and awareness raising. Irina is also a PM Plus trainer, a problem management trainer, and she was involved in projects that focus on fair psychosocial aid digital tools for Ukrainian people affected by the war. Sara Salmi, she's an anthropologist in charge of EU and emergency response project management. She's specialized in crossing of gender and youth while adopting human-centered, in-depth, and observation-based qualitative research methods to generate valuable questions, gain deep insights, and most importantly, translate these results into actionable strategies for impactful change. Finally, we have Alice Bunoro. She's a psychologist with a master's degree in ethnopsychiatry and migration psychology. She's specialized in social development and implementing preventative support and mediation interventions in cases of individual and social distress aimed at promoting the integration of groups who are currently at risk of exclusion or belonging to different cultures and ethnicities. I would like to then give the floor to Dr. Sinje. Thank you, Sinje. Your microphone is off.
All right, yes, it was muted. Thank you so much for the introduction, Pamela. So our project Mental Health Support for Ukrainian Refugees, in short, MESUR, commenced in December 2022. It has a duration of 2 years. If we can go to the next slide. Our geographical coverage in this project is Bulgaria, Estonia, Germany, Greece, Hungary, and Poland. And our consortium members are mental health experts and researchers in the field of mental health. Can we go to another slide? Yeah. So our general objective in MESUR is to provide immediate mental health support for displaced people from Ukraine facing depression. By providing immediate mental health support, we aim to reduce pressure in the 6 project implementation countries. Our aim is also to provide training health professionals working with displaced persons with depression. At the end of the project, we aim to deliver a best practice guideline and implementation toolkit to further countries, but not only involved in MESUR countries. Next slide. So yeah, our target group in this project is displaced people from Ukraine who are currently in depressive episode, who are vulnerable to depression and for whom depression treatment has been disrupted. And the next slide. Yeah. When we look at our intervention, so our intervention includes called I-5 Depression Toolkit, and it has 3 main components. So the first one is a website we call awareness website because it provides comprehensive information about depression, its causes and treatment options. And the second part is the digital mental health tool, which is for patients and healthcare professionals. I will give further information on that a bit later on. The third component is the training. This part is for interested healthcare professionals who would like to offer our tool to their patients. We ask them to complete this online training and then complete a quiz. If they pass this quiz, then they're eligible to offer this tool to their patients. So the next slide. Yeah. So the first component, our awareness website, it is aimed for general public, healthcare professionals, family and friends. It has information on causes, symptoms, and treatment of depression. It is currently available in 20 languages, and it includes sources of help in many countries. Next slide, please. Our tool, I Fight Depression tool, it is an online self-management tool, and it is used with a guidance from a trained health professional, such as general practitioners, psychiatrists, psychotherapists, or clinical psychologists. And it is disseminated internationally by us, European Alliance Against Depression, and it is based on cognitive behavioral therapy principles, and is free of charge for healthcare professionals who would like to be guides, and for patients as well. Next slide, please. Yeah. So this slide summarizes the usage information for our tool. Our tool is available in 16 languages, and it is used in 12 countries by more than 28,000 people. And we have 2 versions available, one for youth and one for adults. And yeah. So of course, since it's a digital mental health tool, users can freely choose when and where to use this tool. It helps people with mild to moderate depression to self-manage their symptoms, and it encourages people to recognize and change patterns of thinking. Yes. So how do we provide access to I Fight Depression tool? So first of all, as mentioned before, like any healthcare professional is contacting us to become an IFD guide, and then we direct them to complete an online training. In this training, there is also information about the recognition of depressive symptoms and trauma that are prevalent among displaced communities, and also how to offer this tool to the patients in their daily practice. So after completing this training, we ask them to complete a quiz, and if they pass this quiz, then they offer this tool to their patients. But there is one thing, one important information for this tool. It is not a standalone tool because depression is a serious mental health disorder. That's why we always suggest them to receive usual care and treatment besides using I Fight Depression tool. Yeah. So this is the login page of our tool. We ask each participant to fill in the mood questionnaire, because this gives them an insight about their depressive symptoms before utilizing the tool. And the next slide, yeah. Yeah, and then we ask users to fill out this mood questionnaire once in a week, and then it creates a progression curve, whether to see the symptomology improved or not. And it has several exercises and explanations available online or as printouts. There are several worksheets and case examples. They are all based on scientifically validated information. I will not talk about this slide more in detail due to time constraints, but it overall shows us the outline of the workshops included in the IFD tool. It gives them an insight about, for example, how sleep and depression are linked, and how regulating sleep schedule can improve their depression, and how to identify negative thoughts and how to change those thoughts. Yeah, we can skip this slide, and we have optional workshops as well. So overall, the things that patients can learn from using I Fight Depression tool is that negative thoughts patterns can be changed, and they also have a chance to get a realistic picture of their own mood, and they also learn how depression can affect the way they perceive their environment, and how to structure their everyday life actually can have an influence on their depressive symptoms. So far, our achievements with MESUR is that we were able to develop 2 workshops with the assistance of our mental health experts. So one workshop was focusing on healing trauma, and the other one was coping with loss. So it provides information about how to support users with grieving process and how to cope with traumatic experiences. And the next slide, yes. And this is actually a screenshot from our tool. As you can see here, we have many available workshops in Ukrainian language, and these are the sub-content of the workshops that we developed. And the next slide, please. Yes. And we also added some content to the website. We now have some content available for displaced people from Ukraine, like how displacement affect their mental health and what depression is and what trauma is. Yes, and next slide. Yes, thank you. So all those developed workshops content were translated into Ukrainian and Russian with the assistance of native speakers of Ukrainian and Russian. Next slide, please. Yes, so thank you. This is another component of our project. So we have also an IFD guide website available. This is also translated into Ukrainian and Russian. What I mean with that is that all like some healthcare professionals who are providing this tool are listed on this website. So the visitors or users who would like to use this tool can go to this website and choose their country of residence, and they can see a list of healthcare professionals who offer this tool. Yeah, next slide. Our achieved progress with the IFD toolkit update is that we have now more than 400 users for the Ukrainian version of the tool, and more than 86 users for the Russian version of the tool in 6 countries of MESUR in total. Next slide, please. Yeah, so when we look at the country distribution, majority of them are coming from Estonia and Germany. We have had challenges in reaching out to Ukrainian displaced people in Hungary and Greece and Bulgaria. And that's why the numbers are lower when compared to other countries. Yeah, so as a solution, because it was in the beginning, it was kind of hard for us to find guides who are displaced mental health professionals themselves. That's why we made an exception to our tool, and we decided to offer the tool in an unguided version to reach as many people as we can who are in need. That's why we also have 300 users for the Ukrainian version of the tool, in addition to the guided version, and we have 4 users for the Russian version of the tool. And the next slide, yeah, this is the, again, country distribution. It's a similar distribution. We can skip it. Yeah, and for the healthcare professionals that we recruited so far, these are the numbers, but we also decided to recruit social workers as guides because they are frequently in contact with the Ukrainian displaced people, and we thought that we would broaden our approach, and we would also offer them training in recognizing depressive symptoms and trauma. So that is why these numbers reflect the healthcare professions as well as social workers recruited for the project. Yeah, and this is my last slide. So we will increase our efforts to reach out to Ukrainian displaced people until the end of November, until the project closure. And we are still training, providing training to health professionals and social workers. And we are also going to prepare a best practice guideline and implementation toolkit. So that's all from MESUR. Thank you very much for your attention.
Thank you very much, Inge. I would like to invite Dr. Frankova to present the URISE project. Hi, Irina, your microphone is up. Perfect.
Yes, thank you so much, dear colleagues and organizers of this webinar for bringing this important topic. I want to make sure that interpretation works fine, whether you can hear the interpretation. Please, you can send the text message to the chat if it's fine. Because there was one occasion when 2 interpreters were talking at the same time. I think now I hope now it can be solved, so only one interpreter would interpret. Okay, fine. And Pamela will help me to change slides, so next slide. And here I represent URISE project that was and is co-funded by European Union. And it is coordinated by Vrije University Amsterdam, the Netherlands. I can see now that again 2 interpreters are talking. So now Leon is interpreting. Great. So this project, same as MESUR project, was developed in order to provide psychosocial support to Ukrainians displaced in 3 bordering countries, in Poland, Romania, and Slovakia. And we have a number of partners, some of them academic partners as WU. For example, we have University of Verona and University of Luxembourg and ARC National Psychotrauma Center. But we have as well 3 implementing partners, and those are international and national level NGOs that were already active in psychosocial response to the at the beginning of the full-scale invasion. So in Poland, it's International Medical Corps. In Slovakia, it's Disseminate, one of the largest NGOs in psychosocial support in Slovakia, and in Romania, HaDEA. And our tasks are to engage Ukrainian-speaking psychologists displaced in Europe in order to provide psychosocial interventions in the same language and without the barriers. And we do implement face-to-face interventions like Problem Management Plus, Self-Help Plus, and multifamily approach. And we do implement 2 digital interventions. Next slide. Next. Yeah. So you would ask, why 2 interventions? Why 2 digital interventions? Why 1 is not enough? And there are at least 2 reasons I can share with you. So first is timing. When the traumatic situation happens or traumatic experience, we do need different type of intervention compared to the situation when somebody is in ongoing stress for a long period of time. And if you would look at the bottom of this page, you would see that based on the current neuroscientific knowledge, there is so-called golden hours or window of opportunity right after exposure to trauma, when we can still interfere with the trajectory of somebody's symptoms and reactions to the trauma. So for that specific golden hours, we do have a digital mental health intervention, chatbot-based intervention called Friend. And you can see that this intervention could be applied for a large number of people, basically to all the population affected. And according to this an intervention pyramid, it is the first layer, the basic psychosocial support. And I will give you more details about this specific intervention. The second one, called Doing What Matters in Times of Stress, and the platform, how it's delivered, its website. And this intervention would be applicable for the third layer, psychological support, because this intervention actually aiming at already existing symptoms of anxiety, depression, and to some extent to symptoms of post-traumatic stress. Next slide. So This was too fast. Pamela, can you please go back? Thank you. So as I already mentioned, the chatbot intervention, which is actually a micro intervention, it takes only 20 to 30 minutes, was inspired by current knowledge in neuroscience. And when we were working on the guideline on risk management after a terror-induced stress within first day to 1 month, we realized that there is a number of evidence-based intervention that actually showed effectiveness in preventing of PTSD right after exposure to trauma. But the problem is that those interventions should be delivered as soon as possible. And in case of mass casualty or emergency situation, you will not find enough mental health or even social workers to provide this within first hours or first days. We started working on the development of digital intervention, next, which was based on the principle of first ecological aid. Next. However, when the full-scale invasion happened in 2022, we realized that those principles are not applicable to the ongoing life-threatening situation, because in many cases, safety is, we just cannot afford safety. A number of international experts helped us to contextualize the chatbot intervention to the context of war in Ukraine. This is a decision tree chatbot, meaning that based on the questions and answers received, users would receive different types of recommendations based on some psychoeducation, what should be done right after exposure to traumatic experience, what shouldn't be done, some relaxation techniques, and as well we have an opportunity for people to apply for online session with the psychologist if they feel that this is not enough for them. So there is a principle of step care in this intervention. And Telegram is a messenger that is widely used in Ukraine. But basically, same approach can be applied to other messengers like Facebook or Viber or WhatsApp. Next slide. And I must say that we were able to launch this intervention on the second day after the full-scale invasion, and within the first month, we got more than 40,000 users, meaning that our attempt to apply this digital intervention within the window of opportunity or deliver this knowledge as soon as possible was successful. We also launched a satisfaction survey, and we've learned that for more than 85% of the users, this intervention was acceptable and satisfactory. And many reported that this is a great alternative when there is no one to support. Or as well, another portion of feedback was that we are lucky that we received this important information on how to deal with symptoms of panic, anxiety, somatic symptoms of stress, and there was no need to communicate with the human. However, there was a portion of users, about 15%, who sent us feedback that this was not a good experience for them. And we've analyzed their responses to us, and we are very grateful to those 15% who send us details what was wrong, because that's how we could improve the service. And we can divide those negative feedback in 4 domains. there was some technical issues, and some participants shared that the chatbot is too predictive, too predictable. It's linear and it's not individualized. They were willing to receive answers to their specific questions. Some people reported that there was no effect or no improvement, that this was a short-term effect. And as well, they shared their concerns that actually self-help may be a source of support in this situation. Some reported that this was not contextualized enough, for example, for those who live in occupied territories or work in active combat zone. And we as well have seen a number of unmet needs. For example, people were struggling not with stress, acute stress or panic, but with low mood, low motivation, and some intrusions. Next slide. So that's why we have two digital interventions in URISE project. And the second one is doing what matters in times of stress. And this is a digital smartphone-based, again, self-help intervention based on WHO psychosocial program called Self-Help Plus. And Freie University hosts this website. What is important about this app, and you can easily access it through the website called wmmatters.eu, or you can scan the QR code, that this intervention was developed for people who live in adversity for a longer period of time. And we know that people who have forced migration as part of their experience, when they come to new environments, they have cultural shock, they have number of questions to solve, practical questions, but not always capable to deal with the symptoms of anxiety. And at the same time, they really need to invest into their, basic solving of basic things. Therefore, this program includes 5 modules, and participant or user can access those once per week. And this is transdiagnostic intervention, meaning that it was developed not just for symptoms of one condition, let's say depression or anxiety or PTSD. It targets at the same time number of symptoms. And therefore, the authors of this intervention, they selected 5 most effective and most needed strategies for people to teach them how to cope with adversity. For example, how to deal with stress, how to deal with unpleasant thoughts and low self-esteem, and how to keep a positive view of the future and once somebody's abilities to deal with these issues. And this is available in Ukrainian, Russian, and English. This is free of charge. And the effectiveness of this intervention was tested in several randomized controlled trials. You can see one of the links. This specific study showed effectiveness for medical or health workers during pandemic. We are really looking forward to read an article that soon will be published by our colleagues from University of Verona about the effectiveness of this intervention for refugees in Italy. Next slide. And next. And my last 2 slides are about the challenges that we faced in this process of implementation and lessons learned. So recently, our colleague from the University of Verona, Monika Bartosz, she conducted qualitative assessments of needs of Ukrainian forcibly displaced persons in Poland, Slovakia, and Romania. And she was able to identify the barriers that prevent people from access to mental health services in those countries. And she was able to identify, I can see now that again, two interpreters talking at the same time. So maybe it's time for Natalia to translate. So she was able to identify barriers for face-to-face interventions, but as well to digital interventions. And we can see definitely that unfortunately there is a lack of trust from both users and service providers to digital mental health interventions, and lack of awareness of its effectiveness. And as well, one of the issues is that service providers, they kind of do not believe in effectiveness of those type of tools, because they think there is no therapeutic relationship. Therefore, yeah, you cannot benefit from that. And next slide. So what we have learned since the beginning of the project in December 2022 actually is that humanitarian and complex emergency context is a promising area for digital interventions, both for universal and indicated prevention tools. We have seen the value of digital formats during the golden hours or within first hours and days. We can definitely see the importance of transdiagnostic type of interventions that target more than one type of symptoms, but rather are focused on problem solving and strategies on how to deal with adversity. We can see the importance of step care approach in digital interventions as well. And we are very happy that this webinar is taking place, because more awareness about the effectiveness of digital interventions is needed, both among users and among service providers. And of course, it would be great to have randomized controlled trials in low and middle income countries conducted within populations were affected by crisis. Next slide. Thank you so much for your attention. And of course, that would be not possible without the whole team of URISE project. Thank you.
Thank you so much, Irina, for this amazing presentation. I would like to move forward now to Well You, and I invite Sarah and Alice.
Thank you, Pamela. My name is Sarah, and I'm delighted to be here today representing the Well You project. So thank you, Pamela, if you just move to the next slide. All right. Can you, okay, sorry, my laptop was frozen. All right, great. So the Will You project brings together international organizations, including South Children Villages Italy, South Children Villages International, World Child Holland, Caregivers Hungary, Greece, and Romania. Our project focuses on building capacity for universal, evidence-based, preventive mental health psychological support intervention. These interventions are designed so they can be easily implemented by a properly trained and non-supervised specialist, aiming to reach a large number of people, particularly refugee children and their caregivers affected by Russia's war of aggressions against Ukraine. This approach to mental health addresses the mental health gap and align with the EU missions to ensure access to vital mental health support services. Speaking of mental health treatment, now I will leave the floor to my colleague Alice, who will present to you the data and figures that have propelled the Well You Project Consortium to take action. Thank you.
Thank you, Sarah. And hi, everybody. So as Sarah was mentioning, the Value Project is a response to a urgent need. And before I talk about the treatment gap in assessing care, I just want to give you some numbers to understand the hugeness and the scale of the current situation. So currently, according to the UNHCR data from 2023, Ukraine is the third largest country in terms of refugees, with 5.9 million people displaced around Europe. We know that people with refugees background often need psychosocial support due to migration-related stress. However, a lot of studies highlight that there is a huge gap in acceding to the mental health care system. We don't have time to analyze in deepness all the barriers, but let me just highlight that all the barriers can be divided in two larger groups: the instrumental barriers and the attitudinal barriers. The instrumental ones are related with all the legal, cultural, linguistic, administrative, and cost-related factors, and also the different focus on symptoms of mental health disorder among the countries. Talking about the attitudinal barriers, the first barrier that appears among Ukrainian people is the stigma related on what is mental health and how the person that has a mental health condition is perceived in the society. This comes from the Soviet era, when the psychiatric system was used as a tool of repression against those who were trying to opposing to the regime. This can lead us to another barrier, that is the lack of trust in mental health care system and in mental health care professionals, mostly in terms of confidentiality. Then other barriers are misconception and lack of awareness. So a lot of people don't have, as Irina was stating before, are not aware of what a mental health disorder is, or how we can make how we can perceive a mental health disorder and condition. Other people prioritize other basic needs. So they don't give the priority to their mental health because they didn't find a solution with two other basic needs. Please, Pamela, go on to the next slide. And to discuss the stressor of displaced people is really important to take examine the migration in its total process. That includes all the phases and the stages that you can see in this image. So there is the pre-departure phase, the transit phase, the arrival one, and the return and reintegration phase. All these phases are linked by the cross-cutting aspect that are like age, gender, religion, and a lot more. The pre-departure, I don't have time to go into all the phases, but let me just say a few words. So the pre-departure phase is the phase connected with all the history of the person back in his country. So if in the country there is war, there is conflict, if the person back in his country have access to a mental health care or health care, if the family has a socio-economical status that can help the person to have a decent life or not. Then there is the transit phase, that is the phase that is connected with all the migration process itself. So here just a few words, but in this phase, the main risk is the type of migration. So if it's a mass or a single person that is moving, if a person is victim of smuggling or human trafficking, or again, the being outside of his country and being far from the family, being isolated, or being victim of or tortures or abuses. Then it's the arrival phase. This phase is most likely the phase where the syndromes appears. The arrival phase is connected with all the problems that the person faces once he or she arrives in the hosting country. So the person can face problems with the documents or accessing the healthcare, or again, it can be isolated or unemployed. It can face struggling to reinvent himself, because usually there is a change in what he was doing before and what he can do in the hosting country. And also the adaptation and the sense of identity that this person feel and perceive in the hosting country. And then there is the last phase, that is the return and reintegration phase. I will not talk about it, but it's just all the risk factor connected to when the person come back after a long time to his own country. Please, Pamela, you can go on. Okay, all these phases that I was talking can lead to mental health disorder, including post-traumatic stress disorder, anxiety, depression, suicidal behavior, or isolation and cultural syndrome, especially among children and adolescents. Here, I want to put some focus in what is children and how the children and adolescent mental health can be, how migration, can oh my God. Sorry.
Exacerbate. Yes.
Wow. Okay. Sorry, guys. Sorry, everybody. So, how those syndrome can be even worse in children and adolescents. So, we know that adolescent and teenager are face a period, is a stage of life where the self-identity is building, and this self-identity is building thanks to the peer support, the family support, the environment, the values, the culture, the belongings, and all this stuff. You can imagine migration being forcibly displaced. How can this affect to the health of the children and the teenagers? To put some numbers, 1 of 4 children have a parent that has a mental health condition, and one in 7 adolescents live with a diagnosable mental health disorder. In addition of it, half of all mental health conditions start by age of 14 and 3/4 by the age of 25. Unfortunately, most cases go undetected. To put some numbers, more numbers, over 420 million children grow up in a conflict area exposed to violence. It has to be said that 3 out of 4 children with mental health condition do not receive any care. But there is a positive note. It's extremely important. It is extremely important to consider that majority of children and teenagers, when they are supported, react positively. So we need to focus on the support of teenagers and children, because they have a strong coping system that help them to avoid that the trauma lead into and spread into another mental health disorder. So that's why, and please, Pamela, go to the next slide. Thank you. So that's why we adopt an ecological and multi-level approach, considering risk and resilience factor at many levels. So we just said that children and adolescents have a strong coping mechanism. So if we want to understand their healthcare and their health condition, we need to focus on the multi-level approach that say the individual, the family, the community, and the environment. Because if one of these levels is not working, all the system will not work. And why it's so important to focus on the support of children and adolescents in their daily conditioning to face the daily stressor. If we take a look at the pyramid here, we can see that the social support, the support goes in a scale that goes from basic to the top to specialized mental health care. And SOS Children Villages, we used our intervention in the first two levels, the basic psychological support and the targeted psychological support. This is why we want to help and support non-specialized workers in order to have detection and prevention tool to support the children and the adolescent during their daily life, in order, as I was saying before, to avoid critical issues, and if it's not possible, to give them a tool that is serving as a bridge to professional care. Now, thank you, everybody, and sorry, I was a little bit anxious. I will hand it over to Sarah for the details of our interventions.
Thank you, Alice. Very quickly, just building on what Alice has mentioned, given the prevalence of mental health condition and the scarcity of mental health professionals in some area, WillU brings a shift about the approach to mental health. That's why we have 3 key actions. The first one is adapting and contextualizing and promoting evidence-based scalable solution to ensure that the intervention are coherent and relevant. We then focus on helping non-specialized frontline workers in building their capacity so they can effectively support children and their caregivers. And then finally, we go on by cultivating a vibrant community of organization, individuals that are committed to promote mental health and psychosocial support. So all of these efforts basically contribute to the sustainability of mental health care systems by reducing the burden on specialist staff, allowing therefore to focus on more intensive treatment for those who need it. Pamela, if you can just, thank you. As it was shown in the previous slide in the pyramid, as mentioned earlier, the WillU has a toolbox which includes 4 different tools. The first one is Reach Now and Team Up, both of them developed by World Child Holland, Save the Children Netherlands, and UNICEF in the Netherlands. Then we have Movement, Games, Sports and Creativity, what was developed by Ter de Zom, and it aims to enhance the resilience of children and young people through movement, games, sports and creativity. And then we have PN Plus that was delivered by World Health Organization, PN Plus meaning Problem Management Plus. On the left bottom corner, you can see the age range to which these methodologies are relevant and applicable. And all of these have been translated into multiple languages during the WillU project, and including Russian and Ukrainian. If you can just go to this next slide, the main question I would have, actually, my apologies, I have switched too early, just back the previous slide if you can. The one just on the left-hand side is why we have decided to use these tools. And the reason is because these are evidence-based, scalable, preventive mental health psychological support intervention, which rely on task shifting and provide crucial advantages. Because they're delivered by non-specialists, these can be optimized where there is a lack of resources, making healthcare more accessible to wider population. And by reducing their reliance on specialized mental health institutions, we therefore also alleviate the burden on the systems. Even in case, and what is interesting about these tools, that even in case of severe emotional distress, there is huge proof out there that they can be simple but effective and safe intervention. I think we're basically out of time, so just in the next slide, my colleague will kindly send in the chat the links with a detailed description on the tools. As we've mentioned quickly, Reach Now is for detecting and encouraging help seeking and referral for children and young people in distress. Then the next one is Team Up, and it's for increasing resilience and well-being of children through non-verbal movement interventions. Then we have Movement, Games, Sports and Creativity, which indeed increases the resilience through those activities. And then finally, we have PN Plus, Project Management Plus, that is a low intensity transdiagnostic psychological intervention that helps manage daily problems such as depression, anxiety, and other issues that can occur in both adults and adolescents. With regards to this final page, it just focuses on the achievements we have reached so far, and our activities. We will probably have time to look at this into more detail later, but they are culturally sensitive and have proved to allowing and enlarging the access, in particular to children. That's why we have reached 700 of them across our implementing countries. We have contributed to the building of the capacity of lay professionals, around 244 of them, through 20 trainings. The last figure on the right-hand side is the number of people that we expect to involve through PM Plus sessions, but the activities are ongoing, so we will probably have an update on this while the project comes to an end. Thank you very much. I think there should be one final slide, thanking everyone for being here, and if anyone is interested in connecting with our community of practice, you can just scan the link or click on the link that will be sent in the chat. It's just a great chance to share experiences and eventually be kept up to date for our training opportunities. So thank you very much, everyone.
Thank you very much, Sara. I would like now to invite all the speakers to turn on their cameras. Thank you, everyone. You have already emphasized some of the aspects that are embedded in the following discussion sessions, but we would like to hear more from you just to emphasize the objectives that we have set for this webinar. So our first question, we would like to know how can we leverage on our unique capacity building strategies that have been discussed today to effectively empower non-specialized professionals in addressing the diverse mental health needs of Ukrainian displaced population, considering ongoing cultural nuances and trauma-informed approaches. You have already emphasized some of these aspects, but just for the audience to have more awareness on this. Irina, would you like to start?
Yes, thank you so much. Because of the limitation of time, I focused only on digital URISE interventions. And I will put the link to this platform to the chat as well. So for example, in URISE project, when we identify a need, so there is a beneficiary who is looking for intervention or for psychosocial support, and for example, there is a waiting list, or he or she is in the area that is difficult to reach, we would consider to start from digital interventions. And let's say in 1, 2, 3, or 5 weeks, this beneficiary might get an opportunity to see a trained non-mental health professional in one of those 3 countries under supervision of the implementing partner staff. So this is one of the approaches that we use. Thank you.
Thank you, Irina. Sinje?
Yes. So for us, when we began the project, our primary goal was to enhance the knowledge of health professionals to address the mental health needs of Ukrainian refugee populations, because we always consider depression as a serious mental health disorder, and depression is the most common mental health disorder in people who die by suicide. So that's why we basically focused on finding healthcare professionals within the project. But we soon recognized the widespread stigma surrounding mental health within displaced communities. And this kind of let us broaden our approach to include social workers, because they are in frequent contact with displaced individuals, and we thought that they could also benefit from addressing the mental health needs of displaced populations. So as part of our project, mental health professionals who are our consortium members developed training materials for both health professionals and social workers. And all those materials were informed by insights gathered from focus groups conducted with displaced individuals themselves. So by leveraging the expertise of the mental health experts and the lived experiences of displaced individuals, we ensured that the content was both clinically sound and culturally sensitive. So we still offer these training sessions to improve capacity building efforts, and these training sessions provide insights into recognizing depressive symptoms and coping with trauma among displaced people. In addition to that, we employ monitoring instruments on a 6-monthly basis to assess the effectiveness of our capacity building initiatives. So this ongoing evaluation actually enables us to refine and improve our strategies to meet the evolving needs of this population. And lastly, as mentioned in my presentation, we plan on documenting a best practice guideline for NGOs, stakeholders, and healthcare professionals. So this guideline will provide a comprehensive roadmap for implementing mental health support for displaced individuals from Ukraine. And by documenting these insights, we even aim to enhance our capacity building efforts. So overall, through this monitoring, collaboration, and like the best practice guideline, we are hoping to leverage our existing consortium to even increase building capacity efforts.
Thank you very much, Cindy. Sara?
Thank you. I think my colleagues have mentioned quite a lot, and it does overlap with our approach, which was quite multifaceted as well. Firstly, we do prioritize tailoring our programs to the needs of the specific cultural nuances that we have faced. This is why the project is being characterized by continued adaptation and adjustment of the program implementation to consider the specific needs and challenges and opportunities that were ever changing, as the war effects also was always changing. And we made, at the initial stages of the program, of course, there were focus groups and interviews to ensure that the initiatives that we promoted were sufficiently contextualized to the local context, understanding, and environment we were working with. And finally, the idea is that by this not only applies to the final beneficiary of the program, but also to the professionals, so that we, whatever tool and perspective we promote, does create a supporting environment for a holistic development of the support that we provide.
Thank you very much, Sara. I will now move into our second question. How do these strategies that we have discussed throughout this webinar ensure accessibility and sustainability in reaching a larger demographic? I think it comes a little bit obvious at this point, but it would be great if you could give us a short overview on this. Irina? Your microphone is off, Irina.
Thanks. Yeah, the thing is that, for example, in our project, we use a slightly different approach than value, even though we have overlap in one of the interventions, and even one country where we both implement problem management plus, it's Romania. But we do started from the training of trainers. And then the trainers trained helpers and facilitators who are non-mental health professionals. So we did training of trainers in English, but we selected 15 eligible participants for the training. Those were mixed groups. Some of those were mental health professionals from the host community, let's say from Poland or from Romania and from Slovakia. and the rest were psychologists with a Ukrainian background. And then we, having 15 trainers, each trainer provided at least one training of helper, meaning that we could scale up the number of helpers from 15 to 300. Each of those trainers or each of those helpers or facilitators or consultants, they would provide at least 5 intervention at least to 5 beneficiaries, and then we scale up to from hundreds to thousands. So that's one approach. Another important thing is that the training itself took us at least 6 months. When we started the project, we trained trainers and we trained helpers. But having digital interventions, we were able to provide basic psychosocial support from the day one of the URISE project. And so far we had more than 100,000 users of the chatbot intervention and more than 1,000 users of the website. And again, those are different levels. We do not expect that we will have same amount of people in need of basic intervention and more specialized intervention. Thank you.
Thank you, Irina. Sinje?
Yeah. So, I mean, our fight depression tool, because it is a digital mental health tool, I guess, it ensures accessibility and sustainability to a larger demographic, because individuals can easily access and use this tool and manage their depressive symptoms regardless of their location, thanks to this tool. And it's also free to use for patients. So through the MESUR project, so we tailored the tool content and training materials for health professionals, and we did it by closely collaborating with them. Consequently, the tool is now accessible in several European countries, but our tool was actually not developed within MESUR project. It was rather a product of an EU-funded call from 2011. Our tool has been offered since 2016, but amidst the Ukraine crisis, we recognize its potential in bridging the treatment gap and providing mental health support to displaced populations, as this aligns perfectly with our vision and with what we want to achieve at European Alliance Against Depression. At European Alliance Against Depression, we have an extensive network comprising several members and over 100 regional network partners across Europe, Canada, Chile, and Australia. So many of these members also serve as consortium partners in the EU projects that we are involved in. So leveraging this robust network, IFD tool has actually been continuously adopted and translated into multiple languages, ensuring its accessibility and sustainability to diverse populations. So the workshops I mentioned in my presentation developed within MESUR projects have also been translated into Spanish, Greek, and Bulgarian to provide mental health support to displaced populations in these countries, despite it not being the primary project goal. And also the systematic monitoring which I mentioned as a strategy earlier. We identify areas for improvement, for example, how to enhance user-friendliness of our tool. So we continuously optimize our efforts to maximize the accessibility. In addition to all that, at European Alliance Against Depression, we recently secured the funding focusing on Roma community, ethnic minorities living in Europe. This will also allow us to tailor our tool and potentially develop new content to address their specific needs. And so overall, all these initiatives actually enable us to meet the evolving needs of diverse populations, thus enhance the accessibility and sustainability of our project.
Perfect. Thank you so much, Sinje. From the WellU project.
Thank you. Just very briefly, as I've mentioned earlier, all of the WillU tools, either targeting adults, children, or young people, are per se very much scalable tools. And that's why the first target that we have is reaching is involving lay professional, therefore facilitating faster scalability and improving the outreach to vulnerable population. There is lots of evidence that mention how there is great potential for scale up in this of these sort of tools. That's why they have been implemented in different cultures, languages, and systems. They are relevant for different age group and population affected by adversity. And overall, they can definitely help addressing the mental health stigma. Yeah, I didn't want to overlap what colleagues have mentioned. Thank you.
Perfect. Thank you, Sarah. Our last question before we go into the Q&A. So what we have been discussing already and reflecting on your experiences, and I know in the presentation of Irina, of Rise and MESUR, and well, you have already discussed some of the lessons that you have learned throughout the project, but it would be great to continue emphasizing of this. How can these insights inform future advocacy awareness efforts and policy recommendations that are aimed at improving mental health support systems for displaced communities worldwide? Irina, would you like to start from your Rise perspective?
Yeah, absolutely. And one of our deliverables as well is the implementation plan, how to kind of expand the experience we've gained for other situations or other crises. And like this is ongoing work. We definitely think that the strategy of task shifting and step care approach is very important. We think that from the very beginning of the project, the concept involving mental health professionals or even non-mental health professionals from the same community and same culture is crucial. It actually works really well with the issues of stigma, because if the intervention is first delivered in the same language and second delivered by your peer, it is different than the experience when you receive, let's say, consultation of a psychologist with interpreter in a different language. So this is absolutely a lesson learned for other situations. And yeah, we as well have learned that interventions developed in other settings for other cultural groups, even being tested and effective, it doesn't mean that they would automatically work for other culture or other language. And as colleagues already mentioned, the focus groups and feasibility pilot studies are very important before deployment of, the full-scale deployment of interventions. Yeah, and again, that's why the representatives of the of people with lived experiences as advisors or as part of steering committees, it's a very important thing to be considered for the next for the future. Thank you.
Thank you, Irina. MESUR representative Sinjin.
Yeah, I mean, the points that I would say actually are kind of confirmation from Irina. As she mentioned, we are still in the implementation phase, and our key lessons learned are still ongoing, and we will be summarizing all those key lessons learned from the best practice guideline, which we will deliver at the end of the project. But so far, I can say that during our implementation phase, we observed that mental health specialists lack confidence in providing culturally competent services or war-related mental health support to displaced people, with language barriers posing additional challenges. So interpreters are often necessary for mental health support to displaced populations or migrants, refugees in general, but there's a shortage of qualified interpreters proficient in this context. Thus, I think increased funding and resources dedicated to mental health services for refugees and migrants are needed, including the development of culturally appropriate and accessible interventions. I guess policy efforts should consider integrating cultural sensitivity training into health professional curriculums. Maybe that's one solution. In addition to that, we have had challenges and we are still having challenges on how to effectively reach to Ukrainian displaced people, given that their help-seeking behaviors are different compared to native population in European countries. So we think that there is a pervasive stigma surrounding mental health within displaced communities, and this contributes to this, like making them less likely to seek support. That's why we are just focusing on intensifying our efforts for dissemination activities about the existence of our tool. I think our experiences underscore the importance of targeting awareness efforts for the existence of these tools, because and I think these are like important tools. First of all, some of them has evidence-based nature, and they are responsive to the cultural background of the patients. So in that sense, policy efforts and advocacy efforts should be focusing on raising awareness for the existence of these tools. So far, these are the lessons learned from MESUR, but I am sure we will have more lessons learned at the end of the project.
Perfect. Thank you very much, Singen. From the value perspective.
Thank you. As I'm the last one speaking, I would only add that it's evident, because we're all here today, that thanks to these EU fundings, we all had the opportunity to bring mental health and psychosocial support to the spotlight, which is often a very much overlooked area of public health. So this is one of the main, I think, achievement of today's webinar. I won't overlap too much on what colleagues have mentioned, but many populations do hold a strong bias against mental health. So it's very important to continue promoting scalable, accessible intervention that can function on, that can affect on prevention and detection, to continue ensure that a wider amount of children, young people, and people in need can access specialized services. Then, of course, we are also on the learning process. But what is evident in Italy is that the way in Italy and in the world, and some of the partners implementing countries, that it's important to prioritize intervention over treatment alone, and bring forward a shift in the mindset that national governments hold towards a rather more public approach of mental health. Then finally, we will also have some publicly disseminated documents highlighting all of this, but so far has been to us instrumental to train lay professional and across professional and volunteers across Europe, so they can debunk stigma and taboos around mental health. So far, this is our best achievement, and thank you very much.
Thank you very much, Sarah. Okay, then since unfortunately we are running out of time, I have seen one interesting
Ukrainian interpretation in the English channel.
Exactly. I'm hearing the Ukrainian interpretation at the moment. Okay, I hope it works well now. All right, perfect. Then to end, since I have mentioned before, we are unfortunately running out of time, then I will just post one question that we have found here on the Q&A. It's from Maria Bray. She says, thank you very much for the interesting webinar. I have two questions. I see PM Plus was placed in level 2 of the pyramid, but is it not a level 3 intervention as it targets specific groups needed focused support? Second question from Maria is regarding digital mental health. Have you identified lessons learned, best practice to ensure client buy in the digital approach and continue to use it regularly and not drop out, especially for children and young people? I think these questions are relevant for all of you, for all the 3 projects. Irina?
Yeah, thanks. I would refer to digital interventions, and so what we've learned at one point of time, we decided to, and I'm talking about chatbot intervention. This is a very easy entry point. You just click a link and you immediately start communication in the messenger with the bot. And when we launched the feedback form and satisfaction feedback, we learned that people use the tool not just once, but for example, one of the feedbacks was like, I got this link from my friend, and she said, look, this is, it helped me when I was in stress and in panic, and I just activated the chat and forgot about it. And then when I was in a shelter and there was a major missile attack, I started feeling panic attacked. And I remember that I have this tool in my pocket, and I started the conversation and it helped me. So when we received this feedback, we started sending a reminder to our users that, hey, how are you? What is the level of stress today? And this specific question was sent out as a reaction to a major stressful situations in Ukraine. For example, a Hovka Dam explosion, or major missile attacks during the Christmas time, etc. And we saw, based on the statistics, that the number of people using the chatbot in the periods of those major distress increased from hundreds to thousands within the day. So that's our lesson learned. Unfortunately, we don't have specific targets, children as a specific target, but we ask our users whether they have small children. And if they say yes, so we provide relaxation recommendations for children as well. That's the way how we can support children in this way. So I think that feedback form is a crucial tool for digital mental health services.
Perfect. Thank you, Irina.
I'll just pop in with a question regarding PM+. This is actually very interesting because it's one of the main issues we had facing in Italy. Indeed, if we speak about general way PM+ should be located in a pyramid, by supporting people presenting with some level of stress, PM+ should act as the indicated prevention ladder of the pyramid. So indeed, it should be on the 3rd level. However, Alice and myself, being in Italy, we had to lower it to the bottom level because it is being delivered by non-specially mental health professionals. Therefore, it just falls underneath it. So this has to do with also the adaptation of the tool, which is ongoing and has been a huge question of debate. So as a general line, it should be on the 3rd level. However, in the Italian context, due to the ontological framing of MHPSS support, it needs to be at the bottom one. So we would be happy to talk about this further if there are other questions offline. Thanks.
Thank you very much, Sara. From MESUR side, is there anything else to add? Thank you.
I can briefly comment on the dropout rate for the digital mental health tools. So yeah, unfortunately, it's common for our tool as well. But what we find effective is that we also recently conducted a study about that, because our tool is offered guided. This helps with decreasing of the dropout rate. But so the IFT guides for us are usually general practitioners or psychotherapists, and the dropout rates actually show changes based on the profession of the guide. For example, in our study, we recently found that if the guide is a psychotherapist, the dropout rate is relatively smaller when compared to general practitioners. So there are several actually factors that contributes to that. And also sociodemographic characteristics of the person for us makes a difference. Gender, age, or the severity of the depression plays a role. So we also use like notifications to remind the user to continue using the tool. This is also helpful to a certain extent. But I would say maybe the main factor will be that if it is offered and discussed by a guide or by a healthcare professional, so that patients stick to it more often.
Indeed. Thank you, Singe, for your answers. Unfortunately, we have run out of time, but before we close, we would like to ask our participants, attendees, to please answer this short poll. Heidi, could you please launch the poll questions? Okay, thanks everyone for answering our poll questions. Unfortunately, we have to wrap up the webinar at the moment. I know there are still a lot of questions on the Q&A. Please feel free to reach out to the links that we have provided on the link from all the 3 projects, from MESUR, URISE, and WellU. And we are really looking forward to receive all your comments, questions, and everything. Are there any final words from the speakers, from panelists?
I want to propose the topic for the next webinar. I don't know who can host it, but I think it's definitely of interest And this would be a topic of regulation in European Union of the mental health digital interventions, both in prevention, but as well as treatment of established disorders. Thanks.
Thank you, Irina. We'll keep it in mind. Well, thank you, everyone. Thank you, Irina. Thank you, Sinje. Thank you, Alice. Thank you, Sarah, for your time and for this truly amazing webinar. And we hope to be able to connect with all of you. Have a great afternoon, and thank you so much again.